First one is the Rickettsia. The general properties of Rickettsia have the following characters. Rickettsia are obligate intracellular organism. It will not grow in artificial media. It will grow only on cell line or egg or mice inoculation. Except Bartonella species, it will grow on this media. Mainly it is transmitted by arthropod vector, except Coccycelia, which is transmitted by inhalation mode. The order of Rickettsialis, it comprises of genera such as Rickettsia, Orientia, and Ehrlichia. First one is a clinical manifestation of Rickettsia. In Rickettsia, severe systemic involvement is there. The most important clinical manifestation is Rocky Mount spotted fever is seen. In mildest form, Rickettsia pox. Escas are seen in Rickettsia, Rickettsial pox, African tick bite fever, Indian tick typhus, and scrub typhus, in which the escas are seen. Distribution of rash in epidemic typhus, except palm and sole, all other the over parts of the body rashes is seen. In endemic typhus, trunk followed by extremities rash is seen. Rickettsia, Rocky Mountain spotted fever, Indian tick typhus, in which palm and sole rashes will be seen. Vesicular or vertically formed rash, it will be seen in rickettsial pox, African tick bite fever. In Q fever, no rash will be seen. Q fever, in acute Q fever, pulmonary feature and hepatitis will be there. In chronic Q fever, endocarditis will be there. CNS involvement like mental confusion and coma will be there in epidemic and endemic typhus. Recurrent illness, which is otherwise known as Bill sensor disease, which is caused by Rickettsia prowazekii. Tick and mite is transmitted by bite 1 and 2 transoviral transmission. Loss and flea-borne rickettsia transmitted mainly by auto-inoculation following the rubbing of the insect. Aerosol route is also through this way also transmitted by inhaling dried loss or flea fecus in the laboratory or as a part of bioterrorism. Next one is the scrub typhus. The agent of scrub typhus is Orientia susuggamushi. It differs from Rickettsia both genetically. It will lack lipopolysaccharide in cell wall. The vector of scrub typhus is trombiculoid mites of genus Leptotrombidum. Leptotrombidum agamushi in Japan and Leptotrombidum deliensis, which is seen in India, which is the vector. The larval called chiggers, it is a stage of mite. It is the only stage that feed on humans. So scrub typhus is also called as chiggerosis. Clinical manifestation of scrub typhus are mostly it consists of triad of scar at the site of the bite it is seen, and regional limb adeno will be there, and maculopapular rash is seen. The classical triad is seen only in 40 to 50% of affected cases. Antigenic diversity, there are totally major antigenic type. 3 antigenic types is identified: carp, gillium, and Cato. Because of this remarkable antigenic diversity, it is exhibited by the organism. Immunity wanes over 1 to 3 years. Next one is a zoonotic tetrad. 4 elements are essential to maintain O susumashi in nature. Trombiculoid mites, small mammals, example field mites, rats, and shrews. Secondary scrub vegetation or forest, hence named as scrub typhus. In wet season, when mites lay eggs, through this way it is transmitted. Global scenario, scrub typhus is prevalent mainly in Japan, China, Philippines, Southeast Asia, in India, Pakistan, Afghanistan, tropical Australia, New Guinea, and Pacific Island. Indian scenario, scrub typhus is the most common rickettsial disease found in India. The diagnosis of scrub typhus is mainly it is diagnosed by Weil Felix test, in which OXK titer is increased. Next one is the Ehrlichiosis. It belongs to the family Anaplasmataceae. It consists of four obligatory intracellular organisms, which is named as Ehrlichia, Wolbachia, Anaplasma, and Rickettsia. Common to all three species, it is obligate intracellular parasite. It cannot be cultivated in artificial media like scrub typhus, so it will grow in culture cluster inside the phagocyte like mulberry-like inclusions, which is known called as morula. Next one is a laboratory diagnosis of rickettsiosis. The most common diagnosis is Weil Felix test. It is a heterophile agglutination test in which the antibodies are detected by using protease strain OX19, OX2, and OXK strain due to sharing cross-reacting alkyl stable lipopolysaccharide antigen. The procedure for Weil Felix test is it is a tube agglutination test. Serial dilutions of patient sera are treated with non-motile strains of Pseudomonas vulgaris OX19 and OX2 and Proteus mirabilis OXK. In epidemic and endemic typhoid, sera agglutinate mainly with OX19. Sometimes it is seen with OX2. In tick-borne spotted fever, antibodies to both OX19 and OX2 are elevated. In scrub typhus, antibodies OXK is raised. The test is negative in rickettsial pox, Q fever, ehrlichiosis, and bartonellosis. False positive will be seen in presence of underlying protease infection. So, fourfold rise of antibody titer is paired sera is more meaningful than a single high titer. Next one, false negative result will occur due to excess of antibodies in patient sera, which is known as prozone phenomena. It is obviated by testing with serial dilution of patient sera. Wales test is being a non-specific test. It should not be always confirmed by specific tests. Next one is a specific antibody detection test. First one is the indirect immunofluorescence assay. It is one of the most common serological tests which is used for the confirmation of diagnosis. Complementary fixation test. It is more specific, but it is less sensitive. Immunoglobulin M capture ELISA. It is useful only for the earlier diagnosis within 1 week with excellent sensitivity and specificity, and latex agglutination test is used. Next one is the Bartonellosis. These species are fastidious, intracellular. It is a gram-negative bacteria. It has the ability to invade the RBC. It differs from other Rickettsia because it can capable of growing only on the blood agar. First one is a Bartonella henselae. It will cause cat scratch disease. It is a typical form. It occurs in about 90%, in which lymph node enlargement will be there. Most common site is axillary or epitrochlear, in which a painless pustule is seen. Atypical form, only 10% is seen. It involves various organs. Warthin stearate silver nitrate staining is used, and bacillary angiomatosis seen, in which neovascular lesions in skin and other organs is seen. It is mainly seen in HIV infected people. Other disease such as bacillary peliosis, bacteremia, endocarditis is seen. In Bartonella henselae, the main reservoir is cats and other felines. It is transmitted by exposure to cat by scratch or bite, cat fleas associated with cat to cat transmission, but not cat to human transmission. Next one is the Bartonella quintina. It will cause trench fever, quintinator 5 days fever, and chronic bacteremia, endocarditis, bacillary angiomatosis, in which neovascular lesions in the skin and other organs will be seen. The main reservoir is humans. Transmission is through loves, and Bartonella bacilliformis. It will cause Carrion's disease or Oreo fever, which is a systemic illness. Verruca perina cutaneous vascular lesions is seen. The reservoir is human. Transmission is by sandfly. Next one is the chlamydia. Chlamydia is a obligate intracellular gram-negative bacteria. It will not grow on artificial media, but it will grow on cell line, egg or mice inoculation. Chlamydia is a infiltrable, but it will produce inclusion bodies like virus, but it differs from virus because it has both RNA and DNA, and it will possess modified peptidoglycans, so it differs from other viruses. It cannot produce their OTP, ATP, so they are called energy parasite. They are dependent on host cell adenosine triphosphate. It will show trophism for squamous epithelium and lymph node. Life cycle, it will exist in two distinct morphological forms. One is elementary body and the other one is the reticulate body. In elementary body, it is extracellular form, infectious form. Metabolically, elementary body is inactive. It has rigid cell wall and very small in size. Nucleus is electron dense. RNA and DNA contents are same. In reticulate body, it is intracellular form. It is replicating form, metabolically active, fragile cell wall, and it is large size. Nucleus is diffuse. RNA content is more than DNA. Next one is the Chlamydia trachomatis. It is the most common cause. Only one serotype community acquired atypical pneumonia associated with atherosclerosis and asthma, sexually transmitted disease, non-gonococcal urethritis, post-gonococcal urethritis, pelvic inflammatory disease, and acute epididymitis is caused by Chlamydia trachomatis. Inclusion conjunctivitis, swimming pool conjunctivitis. It is mainly seen in adult. Ophthalmic neonatal or inclusion blenorrhea. It is which is mainly seen in neonate. Next one is the complications of chlamydia. Reiter syndrome will be there, in which conjunctivitis, urethritis, polyarthritis, and mucocutaneous lesions is seen, which is mainly associated with people with HLA-B27 antigen. Most common cause of peripheral inflammatory arthritis is seen in young men. The most common site of peripheral inflammatory arthritis is large joints of legs. These are the complications of chlamydia. Fitzhugh-Curtis syndrome, in which perihepatitis in sexually active women is seen. Urethral syndrome in women is seen. Dysuria and frequency. Urethritis, pyuria, and no bacteria is seen. Trachoma, in which chronic conjunctivitis will occur. Follicular hypertrophy, papillary hyperplasia, pannus, and cicatrization will be there in chronic conjunctivitis. Stages: trachoma dubium, protrachoma, established trachoma 1 to 4. Inclusion body, Halbersteda provesque. It is seen only in established trachoma stages 1 to 4. Limbogranuloma venerum. It is an invasive sexually transmitted disease. It is also caused by Chlamydia trachomatis. The serovar involved are L1, L2, and L3. It is characterized by the most common serotype is L2, L1, and L3. Limbogranuloma venerum serovasum more invasive than other serotype. Incidence is very falling. Male is to female ratio is 3 is to 4 is 3.4 is to 1. Clinical features of limbogranuloma venerum is, in which the painless ulcer is seen. Lymph nodes are very painful. Inguinal lymph node is enlarged, which is known as bubo. Estheomonan, which means elephantiasis of vulva, is seen. Rectal stricture and proctitis is seen. Skin test is positive. Fright test is done. Next one is a laboratory diagnosis of chlamydial infection. Under microscopy, gram staining, often it will reveal sterile pyuria. Neutrophils will increase, in which no organism is seen, as they are purely gram negative, so organism is not seen. Other stains such as Castaneda, Machiavello, or Gemsa stains are better methods to detect chlamydia from samples. The inclusion body is also detected in cytoplasm, which is known by different names: Levanthal coli Lyle bodies, Psittacosis, Miyagawa corpuscle, Limbogranuloma venerum, Halberstadter Provoski body. It is used for trachoma. Lugol's toll use it is used only for Chlamydia trachomatis, which stains the glycogen inclusion body, are used for the diagnosis. Under direct immunofluorescent test, direct detection of inclusion bodies in clinical material, antigen detection, enzyme immunoassay, it will detect chlamydial group specific antigen, lipopolysaccharide. Culture, mice inoculation is done infective by only chlamydial cetacea and limbogranuloma venerum biobus. Yolk sac inoculation is done. Cell culture inoculation is done. MC coy cells and HELA, HEP2, it is used for chlamydia pneumoniae. Serology, microimmunofluorescent test. It is a serological test of choice. It will detect the serova's specific antibody by using the outer membrane protein antigen. Complement fixation test. It is a genus specific test. It will detect the genus specific antibody by using lipopolysaccharide antigen. High antibody titer is seen in limbogranuloma venerum, infant pneumonia, and inflammation of fallopian tube. Nucleic acid and amplification test, mainly PCR, is done. It is the diagnosis of choice because it is more sensitive and specific assay. Almost it is a replacing method, so it is called as gold standard culture. Next one is a mycoplasma. It is one of the smallest free living organism. The general properties of mycoplasma is filterable, so it is known as Etton's agent. Formerly, it is known as pleuropneumonia-like organism because it will lack rigid cell wall. Peptidoglycan layer is absent in mycoplasma and it is replaced by cholesterol. So they are resistant to cell wall active antibodies like beta lactams. Next one is the clinical feature of mycoplasma. The incubation period is 2 to 4 weeks, in which person to person spread is mainly through respiratory droplet. The most common manifestation is the mycoplasma will affect the upper respiratory tract and it will cause upper respiratory illness. Most commonly, it is associated with community acquired atypical pneumonia, which is mainly seen in adults. Pneumonia is called primary atypical pneumonia. It is also known as walking pneumonia or Etton agent pneumonia. Some extrapulmonary manifestations such as neurological, dermatological, cardiac, rheumatological, and hematological manifestation is seen. Next one is a laboratory diagnosis of mycoplasma. Mycoplasma is a purely gram negative, so it will show pleomorphism and it will resemble like L form. Staining with dye stain, it will block off agar containing mycoplasma colony and added to methylene blue is observed under microscope and mycoplasma will show gliding mobility because they lack flagella and pili. Culture medium, PP yellow broth and agar is used and it will produce fried egg colonies. Antigen detection by direct immunofluorescent test. PCR is more sensitive while culture is more specific. Detection of antibody is by heterophile antibody. Cold agglutination test, it will detect mycoplasma antibody by using human ORBC antigen. Streptococcus mg test, it will detect the mycoplasma antigen by using Streptococcus mg antigen. Next one is a specific antibody. Complement fixation test is done. ELISA for immunoglobulin M, G, and A detection. The combination of PCR for respiratory tract secretion, some serological testing constitute more sensitive, and it is a rapid approach for the diagnosis of mycoplasma pneumonia infection. Thank you.